are recording as well.
Great, I guess we can wait a couple more minutes.
Ah. Hello. Hello.
Okay, how are we looking over there in the conference room? How many folks do we got?
Three. Three,
All right.
Dr. Watley. Yep, three with Dr. Watley.
Okay,
So I think we can, but we are recording as well. I did get that set up.
okay. Looks like
Do
I
you want
see.
to get started?
Sure. And looks like Dr. Godham joined as well from DiMed Residency. Kita, if you want to grab some other residents or encourage them to join too, that's great. We're also going to record it. Okay, I guess we can go ahead and get started. Thanks to
Thanks, Dr. Nettleton. Dr. Nettleton, who works with WMed as well, but is here to give us this brief overview. And he is the medical director of the Calhoun and Kalamazoo County Health Department, Public Health Department. So thank you.
Thank you, Dr. Watley. And this session is really meant to be a brief overview of COVID-19 therapeutics in the outpatient setting. So really kind of a lunch and learn is kind of the idea. And if we have some questions, we can also review that as well. Go ahead and advance the slide. So the SBAR for this presentation is kind of the following. We know that Omicron variant is highly infectious. The preliminary evidence suggests it's less severe than prior SARS-CoV-2 variants. But we also know that it's demonstrated immune escape, meaning those with prior infection, those who are fully vaccinated are also getting infected. We also now know that Omicron variant is a dominant variant in Kalamazoo County. And we anticipate many infections in a short period of time. And despite perhaps having less clinical severity in most folks, the caseload does threaten societal function and perhaps even healthcare operations. So the recommendations for this intervention is that primary care clinicians should be aware of newly authorized antivirals and prefer monoclonal antibody treatments to reduce the risk of progression to severe COVID-19 disease in selected patients. And that primary care systems should also prepare for test to treat protocols. So we'll be reviewing those today. Next slide. So this is just a kind of a summary of disease spectrum, and then also what are our current therapeutics that correspond for intervention to each aspect of that therapeutic spectrum. So of course, we have COVID-19 vaccines to prevent severe disease, hospitalization, death, and infection. We've had prior monoclonal antibodies used for pre-exposure prophylaxis. We've had other monoclonal antibodies used for post-exposure prophylaxis. But we're going to focus on today oral antivirals, Paxlovid and molnupiravir, as well as one antibody monoclonal antibody known as Citromavab, which are really used in those with mild to moderate symptoms in that early disease spectrum. Next slide, please. And we've learned that Omicron has knocked out 2 of our monoclonal antibody treatments that we've used in the past. So now we're down to 1, Citromavab. And we have these new oral antivirals that have been recently approved, or at least, authorized by the Food and Drug Administration. And if you look down to the red highlighted box there, so the relative risk reduction in terms of clinical efficacy for the outcomes of hospitalizations and death as a combined composite outcome for Citromavab is 79% reduction. For Paxlovid is 88% reduction, and for molnupiravir around a 30% reduction. So those are relative risks. It's not the absolute risk reduction. We'll take a closer look at that, but that's the impetus for using these interventions. Next slide, please. So just briefly about Citromavab. It has FDA emergency use authorization, and it's the only monoclonal antibody we have in our arsenal right now to prevent that progression to severe disease. It's in very short supply locally here at Bronson and Borges. It's a single IV infusion, and then you got to observe for an hour afterwards. So again, since it's so limited right now nationally, our local hospitals actually have even more restrictive criteria for those who are eligible to receive it. And those who receive it at no cost with respect to the drug cost itself. So next slide. So at Ascension, the indication remains, of course, those who have mild to moderate COVID-19. They're not on oxygen, but they must be at high risk for progression to severe disease. It's my understanding that it still can be used in the first 10 days of symptoms, which is what it's authorized for. We're going to see that's a little different from Bronson. Be above, and the criteria at Borges is being above the age of 75, being a BMI of greater than 40, immunocompromised, end-stage renal disease on dialysis, severe lung disease on oxygen, pregnancy. And then for those who are pediatric patients, 12 to 17, you got to weigh at least 40 kilos and have a high BMI, immunocompromised, or pregnant. So this is more restrictive than the FDA EUA, but it is prioritizing because of how limited it actually is. So of course, this is subject to change based on supply. Next slide. Bronson, similar indication. Bronson is using it for the first 7 days of symptoms at this time. It has a little different age criteria, is 65 instead of 75, and then similar indications for those who are immunocompromised or pregnant. And then I don't have information about pediatric referrals at this time. After the presentation, I will try to send kind of the referral links of how to get folks into Borges or Bronson for Citromavab if you identify a patient who qualifies. But I just wanted to give the very abbreviated version of the different selection criteria between each institution at this time. Next slide. So I thought we would transition now to the oral SARS-CoV-2 antivirals, Paxlovid and molnupiravir. Next slide. So just some general comments. Both remain under FDA emergency use authorization. So they're not fully approved, but they have the EUA. Paxlovid is extremely limited currently. FQHCs may receive them in the future, including Family Health Center. Currently, it's really being prioritized in the thumb region of Michigan. Right now, there's higher morbidity and mortality. Piravir is now available in Meijer pharmacies only. What we're going to focus on too is that you really got to know the eligibility criteria for both drugs, and you really got to check for drug-drug interactions with Paxlovid. Review of the risks and benefits must be documented, and each patient must receive the FDA patient fact sheet. A complete prescription must be written. Electronic is preferred, as is you can use fax, but no phone-in prescriptions for each one of these drugs. And each one of these drugs must be initiated within the first 5 days of symptoms. Meijer does allude to free home delivery for patients who don't have transportation, but I anticipate there would be a severe delay if that's the case, And again, we're going to see how important it is to try to start the medicine as soon as possible after diagnosis. Next slide. So additional comments. Documentation is really important for the prescription, because then you run the risk of the pharmacist rejecting the prescription. And so it has to be in the prescription. You have to have the high risk qualifying condition that is the indication for the medicine. And there are some examples for you in the slide. And you must also include in the prescription the date of symptom onset, because again, it's only authorized within the first 5 days of symptom onset itself. So if you don't have those in there, the prescription will be rejected. And NDHHS has also issued priority eligibility criteria, and it's going to open up, and it's more of an issue for Paxlovid. Limited availability anyway is really the limited variable in any case. Next slide. So for Paxlovid, it's manufactured by Pfizer. The indications are to treat mild to moderate COVID-19. You must be at least 12 years old, weigh at least 40 kilos, have documentation of a positive SARS-CoV-2 viral test, antigen or PCR. You got to be at risk for high risk for progression to severe disease. And you might ask, well, what is severe disease? I put in the resource section at the end the NIH, National Institutes of Health treatment guidelines, which includes what qualifies as mild, moderate, or severe disease. Next slide. So limitations of use, can't use it in the hospital, can't use it for those who already have severe disease. It's not for pre or post-exposure prophylaxis, and you shouldn't use it longer than 5 consecutive days. It's comprised of 2 antiviral medications. Niraparib is a SARS-CoV-2 protease inhibitor, and ritonavir is an HIV-1 protease inhibitor. And we're going to see also a CYP3A inhibitor in terms of hepatic function. So it's 2 medicines that come in 3 pills, which are dispensed or taken twice a day for 5 days. So really, you get 2 150 milligram tablets of niraparib and 1 100 milligram tablet of ritonavir. Next slide. There are some dose adjustments based on renal function between GFR of 30 to 60 mils per minute. So basically, you take 1 pill of niraparib instead of 2. You avoid it in those who have end-stage renal disease or less than EFGR of 30 mils per mil, or if a person's on dialysis, and you try to avoid in severe hepatic impairment as well. Of course, don't prescribe if you have hypersensitivity to any of the ingredients in the medication. And we're going to take a closer look in that this drug really shouldn't be co-administered with drugs who are highly dependent on the CYP3A, and particularly those who are, it's associated with serious reactions for those who have or CYP3 dependent drugs on their medication list. Next slide. So we're going to take a look how you really got to know those drug-drug interactions. Your pharmacist will have that information too. Be aware of hepatotoxicity. And for those who have undiagnosed or uncontrolled HIV-1, you're only on it for 5 days, but there's theoretical risk of HIV-1 drug resistance. Some adverse reactions, and so these are included when you hit 1 or 2% of those who are in the clinical efficacy trials. Dysgeusia, so loss of taste, or impairment of taste, diarrhea, hypertension, and myalgia. So those 1 to 2% of reactions noted. Next slide. So here is an example of those drug-drug interactions to be aware of. These are those CYP3A drug-dependent medications that are metabolized through the liver. And so if a patient is on, for example, these medications, they should not receive Paxlovid. And so some might say, well, if you just stop the medicine, can they still receive it? And the FDA UA is no, since the drug will still be in the person's system, even if you wait, 24 to 48 hours. And as I mentioned, time is of the essence in initiating this medication in any case. This is not a all-inclusive list of the drug-drug interactions, but it gives you an idea. Next slide. And then there are the CYP3A inducers. Some include the anti-cancer drugs, anticonvulsant drugs, and herbal products. This is just to give an example of just being aware with Paxlovid of these hepatically metabolized drugs that run risk of interacting with Paxlovid. Next slide. So any drug that's under FDA emergency use authorizations, if your patient has one of these serious adverse events, death, for example, disability, congenital anomaly, hospitalization due to a reaction, you are required as the prescriber to report it to the FDA. And the easiest way to do that is on the link that's provided in the slides. Next slide. So the study that supported FDA emergency use authorization was a double-blind, placebo-controlled, randomized control trial. Included adults older than the age of 18 who had at least one risk factor for severe disease, and it excluded those with prior infection or those who had been vaccinated. Over 2,000 people were randomized in the trial. The average age was 56. Half were male, most were white, 45% were Hispanic or Latino, and 2/3 were initiated with the medication at less than or equal to 3 days from the onset of symptoms. Next slide. So this was the example of the efficacy results for those who are not hospitalized and initiated on this medication within 5 days of symptom onset. They also didn't receive monoclonal antibodies at that time, so it was just those who are unvaccinated, no prior infection, didn't get monoclonals, and got the medicine within 5 days of onset of COVID-19 diagnosis. And was shown to decrease all-cause mortality and also hospitalizations. And so 1,000 in each one of the arms of placebo versus Paxlovid. And again, the relative risk reduction overall was about 88%, and then you see the absolute risk reduction was around 6%. Next slide. So just to transition to now molnupiravir, which is manufactured by Merck. Its indications, again, are to treat mild to moderate COVID-19, also for those who are 18 years or older. I'm sorry, is for those who are 18 years and older. Technically, the other pill can be used. We'll go back for the 12, those, if you go back one slide to Paxlovid, 12 years and up was not included in the trial, but they extrapolated for those who are 12 years old to include them in those who were indicated to use Paxlovid. Sorry, now go to molnupiravir. This is exclusively for those who are 18 years and older, have a positive SARS-CoV-2 viral test, and again, have high risk of progression to severe disease. Next slide. So you can't use it in the hospital, don't use it longer than 5 days, not for pre or post-exposure prophylaxis. This is 4 200 milligram capsules of molnupiravir twice daily for 5 days. It does not require renal or hepatic dose adjustments, so that's a little different than Paxlovid. And it works a little bit differently. It actually interferes with the viral replication process. It causes replication errors in the virus itself. Next slide. Warnings and precautions with molnupiravir. It's not recommended during pregnancy or lactation. We'll take a closer look at that. It's not recommended for those who are 18 years or younger than 18 years. That may affect bone or cartilage growth. 1 or 2% of people receive diarrhea, nausea, or dizziness while they were on it. Not yet identified contraindications, and no drug interactions are yet identified. But again, this is under emergency use authorization. Next slide. So this is important information about molnupiravir that is related to reproductive concerns and status. And so if you're going to prescribe someone molnupiravir, you must assess their pregnancy status. And if you decide to use during pregnancy, you should document the risks and benefits of the medication and counsel the patient to enroll in Merck's pregnancy surveillance program. And you can see that there are recommendations, both males and females, of reproductive age. So I'm just going to read this verbatim. Females of childbearing potential should use a reliable method of contraception correctly and consistently for the duration of treatment and for 4 days after the last dose of molnupiravir. Breastfeeding is not recommended for the duration of treatment and for 4 days after the last dose of molnupiravir. Males of reproductive potential who are sexually active with females and share childbearing potential should use a reliable method of contraception correctly and consistently during treatment and for at least 3 months after the last dose. So you might ask, what is this all about? It comes back to the mechanism of molnupiravir and its viral mutagenesis. Since it hasn't been evaluated for this potential, there is some concerns about the germ cells, and since it hasn't been assessed in germ cells, so ovum and sperm, the idea is out of a caution, these are the recommendations for males and females of reproductive potential overall. And so that's just important difference between molnupiravir and Paxlovid. Next slide. Just like Paxlovid, there's mandatory reporting for serious adverse events that you must report to the FDA and through that portal. Next slide. So the study that supported molnupiravir's emergency use authorization was a double-blind, placebo-randomized controlled trial for those who were 18 years or older, had one risk factor for severe COVID, and had symptom onset within 5 days or had included symptomatic patients within 5 days of their symptom onset. This had 1,400 patients randomized. The median age was 43, half were male, most were white, and half or so were Hispanic or Latino. Next slide. So this looks at the efficacy results for those non-hospitalized adults who received molnupiravir in those first 5 days. And you can see, you remember when I touched at the very beginning that there was about 30% risk reduction for hospitalization and death in those who received molnupiravir. The absolute risk reduction is somewhere around 6 or 7%. And so much less efficacious than Paxlovid or Sotrovimab. So Paxlovid and Sotrovimab have greater efficacy than molnupiravir, significantly more. Next slide. This is the time to event analysis for molnupiravir. So on the y-axis is the percentage of those free from hospitalization or death. And then on the x-axis is the days since randomization. Molnupiravir is the yellow line. The placebo is the dotted line. And you can see on the top gives you the perspective, the absolute kind of reduction. And you can see there's not much difference there, right? And so that just gives you the idea. And then the other XY axis is the zoom in of that, going from 90 to 100 there. And you can see the difference emerges. But you can see how there's a difference between the absolute and the relative in terms of the percentage of risk reduction from hospitalization or death. And it gives you the idea of why it's important to talk in absolute versus relative differences, and how that difference is small for molnupiravir. Next slide. So just thinking about the outpatient setting, the flow for COVID-19 antiviral oral therapies, I think this is important, for us to think about how this is kind of rolled out. And again, hopefully in the coming weeks, given how each is in very short supply, particularly Paxlovid, is having a telephone or in-person encounter with the provider, documenting infection, discussing the treatment, the risks and the benefits, making sure we dot the I's and cross the T's with all those requirements for the EUA and for the pharmacist. And I think ideally, having a rapid antigen test or test to treat protocols is ideal for our patients, whether it's out in the curb and then a telephone encounter, or inside the clinic itself, because the patient will benefit more the sooner the diagnosis is made after symptom onset, and the sooner they begin to take the prescription. and the counseling is important there, and then following up to make sure the patient is doing okay. And so this is kind of the flow for if it's available on site. Next slide. And then this is the flow for not available on site. So in other words, a patient is referred to another pharmacy. And recall that molnupiravir is available exclusively at Meyer pharmacies in the state of Michigan. And Paxlovid is not yet available in Southwest Michigan, but hopefully in the coming weeks that will change. So it's about coordinating with your pharmacy with that electronic prescription and all those requirements that I mentioned before to ensure that the prescription goes through. Next slide. I think that's going to be the end. So these are the resources. So I included here the EUA for each drug, the RCT in the New England Journal for molnupiravir, the state of Michigan's oral antiviral eligibility and prescribing guidelines, the side-by-side comparison of each therapeutic, and it's nice because it goes in detail about mechanisms, cost, which variant it works against, efficacy, all those type of things. I mentioned the NIH COVID-19 treatment guidelines, so that helps include what is mild to moderate disease, and also the changing updates when drug trials occur. And then the last one is a slide set that I think I drew upon, particularly for the flow about the Department of Defense and the federal HHS outpatient therapeutic guidelines for all of these drugs. It includes some outdated information. This was published at the end of December. So the other 2 monoclonal antibodies that are listed in there no longer work against Omicron, but everything else is pretty good and thorough and up to date. So I wanted that to be a quick and brief session for busy clinicians during the lunch hour. Happy to take some questions. I'm not an expert on this yet either, since I haven't yet prescribed for patients, but I can do my best to kind of point you in the right direction for resources. Also happy to answer any questions you may have about COVID-19 vaccines.
I did have a question about just any of these treatments and people who have been vaccinated. I've kind of been getting some different feedback, and I tried to contact Borges and Bronson, but I haven't gotten called back yet. We're not vaccinating, or we're not doing monoclonal antibodies for these treatments in people who have been vaccinated. Is that right, or are we considering it?
No, it's about, so yes, you can prescribe monoclonal antibodies for those who have been vaccinated. The idea is to prevent the person from developing severe disease. Now, the thing that may be confusing is if a person has not been vaccinated or has not been boosted, but has received monoclonal antibodies, the recommendation is to not be vaccinated or boosted within 90 days of receiving that monoclonal antibody treatment, given that there is not known what the efficacy of the vaccine be in the person who receives that monoclonal antibody treatment. Does that help?
That does help. Thank you.
Just as a general update, the Julie Kohler, our pharmacy, who's going to be, she's in communication with some of the FQHCs that have gotten the Paxlovid. So she's working on the process for when we are going to be able to order. So we're already on the site waiting to see when we'll be able to get access. The other thing we're working on is the rapid antigen kits, from that we're in the process of trying to order to get so that we can distribute to our patients. And basically you can distribute to anyone. We just have to have a process for tracking them once we're able to give it out. But this is all going to help with the rapid testing.
That's great.
So Julie, we're going to see if we could get some of the antigen kits. The process, the hardest thing is trying to figure out how to actually get, you know, are you in the right portal? So, but we're working on that, so everyone will know when we have the kits available. And
Great.
then once we've got the fabric.
I think that's great. Have folks referred through Epic to Bronson, for example, for monoclonal antibodies? I know I've worked with a couple of the residents to do it. There is an Epic workflow.
Yeah.
Did I hear yes?
Yeah. Yeah.
That was the yes,
Good.
correct. And did anyone over WebEx have any questions?
Okay, well, if it's not, I appreciate everyone. This was kind of meant to be a quick, brief overview, given everyone's busy schedules, and I appreciate your attention.
Thank you, Dr. Nettleton. Thank you for the information. Thank you. And we're going to send it out to the rest of the team.
Great, you're very welcome.
Yes.
Thank you.
Yeah. So Ali, I like some things. So these are the